Okay, got it. And let's see if I can move these along. Okay, good. We are where we need to be. So it's such a pleasure to be here because I also have the opportunity to work with community health workers with the SA Kids Breathe program for asthma. And I see a couple of individuals, at least a couple of individuals from SA Kids Breathe, one of our community health workers. So it's a pleasure to be presenting to you all to talk about really how we can start to communicate now that we have approved, the FDA has approved the COVID vaccine, and that we can have this, respectful bridging, active listening, really trying to give plain language to parents or caretakers that you come across that have questions about the COVID vaccine, and where we can establish key talking points and really how we get through acknowledging that misinformation, disinformation that is out there. So I'm trying to advance. There we go. So I always think, we want to tell a story. And when I think about discussing vaccines with families, I, have developed that story, and then over time, developed it even further. And, one of the things that we need to know are that vaccines have been around for the longest time, even before Jenner had his smallpox experiment in 1796. There were individuals taking cowpox sores and finding that they were getting protected. And I think that's a key feature of understanding that they've been around for a long time, and then they've been advanced, where I had the pleasure of visiting the Pasteur Institute and knowing in the 1880s that really advancement in vaccines was established. And then it actually wasn't until about the 1940s they really started advancing on the other vaccines, such as the polio vaccine, and then other things like Haemophilus, streptococcal disease. And I wish actually that Salk had created and Sabin had created the polio vaccine prior to 1955, because my own mom had developed polio as an infant, and she actually stayed in an iron lung at the hospital downtown, and then had over a year of recovery in the hospital. And now to understand that we've eradicated polio is wonderful. And so, at least in the United States, but we look at why we continue to vaccinate, whether it be we have these smallpox outbreaks, whether we needed to defeat the typhoid fever because it was killing more individuals in the Spanish-American War than the actual war itself. Infant mortality rates were extremely high in the 1900s, and even mortality rates for children less than 5 were increasingly high, and that was during the influenza pandemic. And then knowing that we've made advances, we have an advisory committee on immunization practices that really started to set standards for vaccine delivery, administration, and safety of the vaccines. And then we developed in the 1980s this Vaccine for Children's program, which many of y'all probably know about, that we can give these vaccines to individuals, to children that can't afford it. And then now we're at the point where there has been more vaccine hesitancy and further outbreaks of certain diseases as immunity wanes. And then the COVID pandemic really hit us. And that's where we need to understand, if we look at this, I know this is a busy slide, but nationally, if I look to the left, we can see the highlighted areas of those vaccine preventable diseases. And we can see the case rates and the death rates. The death rates, you can show the years here. So these were back in the day, 1930s to 1940s for diphtheria. But then if we look on further down to the right, that those case rate and death rates really went down substantially. We're still seeing a lot of pertussis as immunity wanes. But in the US, we've done a great job of eradicating illnesses with vaccines. Globally, they still have room to go because countries don't have that access like we do. And you can see pneumococcal disease still in children less than 5 years kills 1.2 million children globally. And you can see that with some of the other bolded areas, how many million that it has caused deaths. For me as a pediatric hospitalist, I still see pertussis, and this is a vaccine preventable disease, but we see it for a couple of reasons: immunity waning. We see it because we have an immigrant population that comes in that hasn't had access to vaccines. And then there might be some vaccine hesitancy that plays some roles. But we know in 2014 that we were still seeing deaths, especially like in areas that don't have that access in Africa. But in the US, even pulling data from 2019, we had over 1,200 infants less than the age of 6 months that were hospitalized. And we see them hospitalized on respiratory support, sometimes ending in the ICU settings, and unfortunately, sometimes leading to deaths. And we've had in 2019 over 1,100 cases, of which I've seen some. And so it's important to continue to understand that we're still faced with some of this vaccine preventable diseases. I'm going to go over this a little bit later, but I have a lot of slides here, and the slides are for you all to have, so that way you can have this as kind of a book of knowledge, and that can further yourselves in educating and then educating individuals that you come across. But we also need to understand why there might be concerns for vaccines, right? And we've had historical instances of where, that things have happened where there becomes concerns. And then there's been instances of just having disinformation. So plain information that is out there that really tries to combat the use of vaccines. That's not true information, but then sometimes misinformation as well. But we've had instances where they are actually of concern that we try to further improve that process. So after the Cutter incident in 1955, it was a lab that was producing polio vaccine. They didn't have all of that advisory council on immunization practices. The approval process was much different. And they've advanced that, and they've made that more stringent because they ended up having obviously cases of polio pop up, and then that had led to disease and death in individuals and in infants. We've had vaccines 1998 when I was in medical school, hearing about the rotavirus vaccine and talking about how it led to the telescoping of the bowel on top of each other, which cut off the circulation and can really lead to severe abdominal pain, and if not addressed, can lead to surgeries for the bowel because it becomes, you cut off that circulation. And then we know about that disinformation about vaccines and autism. So you can see at the bottom that 2003 to 2013, where it took 10 years really to disprove this information that was put out there. With that thimerosal, they even had to remove it, even though it wasn't a complicating issue. But knowing that some of that disinformation has led to some, vaccine hesitancy and protests and really refusal of vaccines. But it's important to know that we have individuals out there that want to still consent to trials for vaccines. During the COVID vaccine administration, even my teen had approached me and was thinking about receiving it after we had my husband and I had received the COVID vaccine, and thinking about being involved in a trial because, she thought, well, I want to try to benefit others. And I see my mom and dad receive the vaccine. I know it's safer. And these were things that we didn't take lightly and really started looking at the data. But then we also know the cons of that. That you can have this fear, and you can have, you can have that potential of receiving the placebo and not the vaccine itself. But knowing that there's even individuals that take that time to go through that process of being part of a trial. And then we know the protest instances, and really trying to understand that as well is important, because it could be from side effects, it could be from misinformation, disinformation, just receiving too many vaccines, having some sort of philosophical or religious belief, or people feeling that it infringes on their personal right or their decision making, and knowing that those processes can lead to this historical instances. And this has been occurring as early as the 1830s, where you had this brought for the smallpox mandate of the vaccine, that there was concern about intrusion of privacy. And then, from there led to this anti-vaccine leagues and other things that would complicate these protests. But knowing that these individuals sitting here, and this was the 2020 mandate for the flu vaccine up north, that people have different reasons why they're standing there and why these things are happening. But it's important to understand that piece as well. So this is where we get into trying to develop those solutions. So we know that people can be hesitant because of these three colored areas that overlap upon each other, whether there's a lacking of confidence, or maybe that they're complacent and not really wanting to take that step forward, or maybe access, which a lot of you as community health workers can understand that maybe they don't have access to those resources. But I know Metro Health, UT Health, UH during the COVID vaccine movement try to make those opportunities to make it more convenient. But if there is, distrust in the government, then we know during the flu vaccine that was, if there was distrust, then you would have a higher percentage that were not willing to vaccinate. And we know that during the COVID vaccine, similar things had happened. But we know that we start to have tools, so that way we can enable individuals to kind of regain that confidence and understand that they may not be in that complacent phase because they've had other family members affected by the vaccines. But motivational interviewing, I know some of my SA Kids Breathe community health workers have received training in that. And that really is a great tool that can help you, especially with trying to get to that point of getting family members to want to vaccinate their children and want to vaccinate themselves. One, you have to understand what's out there, what the public concern is, so that you can prep yourself for the motivational interviewing. So we sometimes see that with the HPV vaccine, and parents feeling like it's too young. But we know that if we build a vaccine response very early on, we don't have to worry about it later. But we really want to get into that piece of motivational training, getting stories, and trying to defeat that disinformation that's out there, especially like on social media. We know from studies in that third bulleted point, I want to really focus on that. The more that vaccine disinformation is out there, the more the campaigns are out there, then you have this increase in the number of tweets, and then you have this decrease in the vaccine coverage. And then you get this cumulative decline over time of 12%. So this becomes this domino effect that can happen. We need to be aware of that. And then we also need to be aware that we as healthcare providers do still enable and do give that consent. And that's important to that parent that's walking in there, that we have that, aside from us trying to answer those questions, that we also have that sheet of paper that gives us ownership to, help them kind of see that information and provide that information to understand the risks a little bit more. And so we hope at times getting that consent can bring that trust. So to understand the COVID vaccine and that dissemination, we have a traditional timeline, which is normally what happens with the vaccine. And then we had, and this is a good infographic, because we had that accelerated timeline and that emergency use authorization that happened. And you can see here that the exploratory and the clinical with the COVID vaccine down here were, that length that they were studying it during that scientific and then that animal model phase did happen over 10 years. It was really the rollout of the clinical trials that they really had to advance. And then that FDA approval, they were right on top of them to get to that point of EUA approval once they got through that phase 3. And now we're at the point where it is approved. And fortunately, we had resources for rapid manufacturing. So it's important to kind of look at that and base sometimes your discussions on that. And then for me as a healthcare provider, I was able to tell them I was on that phase 1, that front line that received the COVID vaccine. I was one of the first individuals, and I could talk about some of the side effects that I experienced. And then knowing that, maybe perhaps that might give a better story of where we're at. I think it's also important to understand that we have a vaccine schedule. These are resources from the CDC that you can just kind of briefly look over. We even have a new immunization schedule since I created this. They've updated it in December, and it's important to know that key piece. But then those key pieces. But then another resource is really kind of what's happening in the community. And the Metropolitan Health District does a good point in really delivering that information. And to see where we're at, you can Google, the San Antonio Metro Health and current data on COVID, and it will pop up to give you kind of where we're at, are we in a moderate concern phase, or are we in the high concern? And right now we're kind of in that medium risk zone where we need to have our guard up a little bit more. But if we look at cases over time, I know this halts at January of 2022. Now we're in January of 2023. But this was important to see because the children are the dotted lines. And it wasn't until really kind of November of 21 that they had opportunities to vaccinate. And so you could actually see so you first started seeing an increase in the number of cases because those individuals weren't vaccinated. And you could see for adults that slight decrease as they started to get vaccinated over time. And you started to see, as you had variants, sometimes a little bump and rise in cases as well. So these were important key features to be aware of. And then even Texas DSHS does a good job in reporting. And it was nice to see that I could use this as I started to talk to families that as kids go back to school, we see more positive COVID cases happening over time to those children. And then now that we have the vaccine available, maybe perhaps we start to see less of those rises. And then we have even staff members that Texas DSHS tracks. So that information is out there and it's important. We do have a ways to go for first dose versus fully vaccinated. This was from a couple of months ago, pulling data. Now we have even 6 months up to 5 years. We have data on that of children being vaccinated, but we still have a ways to go, even from a few months ago for children 5 to 11 that have really gotten fully vaccinated. We've made some jumps from 48 to up to like around 58,000, but we still have a ways to go. We know that our 16 to 49 population is really getting vaccinated, but this also gives you race and ethnicity down here to kind of tell you, what is happening perhaps in your community. This was specifically for Bexar County, that, the Hispanic population had higher vaccine rates over the Black population. So that's important to see and to know, so we know what's happening. So that's where we get into this preparation phase of really where you can start as you really see that parents, and maybe they come to you, you're with them at the library or you're with them at the home, but you want to start to develop those resources. So for us as physicians, we have posters that we put on walls. We really know about some of the stories. Me as a peds hospitalist, seeing kids sick in the hospital with COVID or Miss C, are important stories I can share with family members, because I don't want them there having, being so sick that they're being hospitalized. And we've had kids with they have complicated diseases, and then on top of that, they get sick with COVID, and that leads to sometimes them dying from COVID. So scary events that are happening, but it's important to, understand, also have that information on safety, effectiveness, side effects, and then use your social media platforms and websites to post that appropriate information. And Metro Health is doing a good job of that. And then right here is a link to where individuals can receive the COVID vaccine. I'm not going to hone in on this slide too much, but as I advance down here to the bottom right is this immunization schedule that has been updated from the CDC that you can use as a resource, because it can show you what the doses are, for instance, for Moderna versus the Pfizer, and how many doses that they need to receive. And then when they get the booster dose, there's the bivalent dose. But it's important to know that they've made adjustments to these things to get them to a point where they know that the safety and effectiveness is still there, but they're not experiencing a whole lot of the side effects. So the second key piece, aside from that preparatory phase, is being ready for some of the key talking points. And then I try not to data dump when I'm giving information to parents, or even if I have to give information to the public, if I'm having to do articles or I'm on the news. I'm trying to answer these questions in such a way that I maybe perhaps have those percentages lined up and that data kept there. But I'm trying to answer these questions appropriately and be ready and prepared for that. So one of the examples that I can use is this COVID vaccine and hearing about myocarditis, and knowing that now we have a Lancet article that looked and did a review. And then we also have the American Academy of Pediatrics. They had given a resource as of December for doing a systematic review. So pulling all the articles that they found about the COVID vaccine and instances of myocarditis, and really trying to deliver that information. So right here is my thought process on how I do that. But I take those articles, I look at them, I see, and I get to a point of understanding, oh, this affects usually males, approximately 82% of cases. Most of the cases are after the second dose of the vaccine. And the age group is really the older adolescent population. And I find that most of the parents that are truly hesitant are in the younger population. But then that risk surmounted to about 1 in 15,000 when they specifically looked at males. Versus here's my other side. So I have to think about COVID and pediatric individuals developing myocarditis or MIS-C, so that multi-system inflammatory syndrome of childhood secondary to COVID, where children can develop myocarditis from that. And we have management guidelines, and I've seen children with that. And I see that distribution it affects more of this broadened age group of these children. We've seen up to actually over now with MIS-C, over 8,000 cases and more now than 66 deaths than I've created with this slide. But that risk is higher. So 1 in 3,000 to 4,000, that risk is still low, but much higher than that risk with vaccine and myocarditis. So it's good to write out that thought process and see. And even with adults, we can see COVID and myocarditis cases increase substantially. So this is the other part. So I have the side effects. I have pain, fever, chills, fatigue. Those are the common, even some muscle pain, headache that I see with the vaccine administered to children. And then the contraindications, I better know those, right? Severe allergic reactions to any sort of RNA vaccine or the vaccine components like the polyethylene glycol. Those would be contraindications. And then noting that we have a knowledge base and a reportable base so that we can understand that. And then the most important piece that I can give y'all is to understand that the majority of the population are really, in general, for vaccines acceptors, 70% of that population. And actually 30% are hesitant, meaning that if we take that time to talk to them, we might get them to get to that accepting side, versus obviously you're going to have those cases of rejectors, and that's going to be less than 1% of the population. So this is where, for the COVID vaccine, I can't get into that presumptive approach where we're going to go ahead and give your child the vaccines today. I need to think about that participatory approach, because this is a new vaccine. It may take some time. And so I can use some of the key features, but I have to create a mantra and get to that obvious strong personal recommendation that this is still appropriate. And so you want them to participate and get into that point. And you want to explain that that benefit truly outweighs that risk. So getting the COVID vaccine, obviously you can miss some days from school because of that. You can experience some side effects. If there becomes mandates, then loss of personal choice. We can talk about the variant a little bit in discussion points later, but the benefit is that we still have safety and effectiveness, and the effectiveness, that percent may go down, but if we still get the vaccine, we may still create an immune response that will really decrease the number of days that that individual might be sick, and it might limit hospitalization rates, transmission to others, and you don't have to be in that quarantine state. And then we don't have to worry about those variants. So that's where it comes into play, that I have to think about that process, and we all have to, about motivational interviewing. So I have sometimes 14 to 20 patients to see on the wards with my residents. I go into a room, and if we're going to be talking, for the majority of the time, I'm going to be talking about something concerning, but specifically, if I'm going to be focusing on the COVID vaccine, especially for respiratory illness, I'm going to go take that time to go sit on either the patient's bed or on a chair and really have that close contact discussion with that family. So I want to set that comfortable environment. And then I want to ask them permission. Can I discuss the COVID vaccine with you today? And I try to earn that trust early on, so we, perhaps can talk about other things first, and then they can learn that I'm willing to kind of have that discussion with them with ease, and I'm not going to be judgmental. And then I can ask them where they're at as far as a scaling sort of question. Where are you at on that scale of 1 to 10 about willingness to get your child to have that vaccine? And then I need to also be ready to respond with questions they might ask about the vaccine. So I can restate, I understand you might be worried about the safety, so let's talk about that. And then I can get to a point of trying to really focus on that and not try to bring in other controversial stuff. You want to focus on what they're concerned about, and then you want to regroup and repeat and give them autonomy and support. So this also, as far as misinformation, disinformation, is a great resource to debunk that and to really talk about respectful bridging. So you can get this handbook. It'll be in my references tab online. It's online. And to ask that individual, where did they get that resource from? What website? Where are they at? And then explain where this myth may mislead, and try to explain it one time, because you don't want to over berate them about the myth. You just want to move on to the facts of where you found your resource, and you can repeat where you found your resource and restate, and then putting those complicated facts into your own words. And so that's really important and key, and really thinking about taking that time, that when you do visits with families, that is an opportunity to rediscuss concerns they might have. It takes time. It's usually not a one and done. It does take time. Explaining your meanings of common, rare, extremely rare. So having some of that information, you know, oftentimes saying that, you know, it's 99% safe can sometimes get you that focus that you need to be at for that individual. Herd immunity, and saying where that risk lies for the immunocompromised or those with chronic medical conditions are those infants that can't receive the COVID vaccine. And then use open-ended questions. And we try not to say but, because that negates everything that they might have said. So that's also important. And then most importantly is to tell your own stories. And so if you've seen things, it's okay to tell your stories, because I think that's the most important key piece that I use as an individual and as a physician, to tell those stories. And then if you feel empowered to further discuss with schools or organizations, that's where you can take those opportunities. But here are the resources. I know I went a little bit over, but wanted to open this up for questions and such.
Thank you very much. Thank you very much, as always, Dr. Svatek. Very, very informative, very good information. Is